I do apologize for my delay.
Okay, تفضلوا.
Okay. Assalamu alaikum. My name is Mohammed Hassousa. I'm pediatric consultant gastroenterologist, National Guard Hospital, Jeddah, Saudi Arabia. It's my pleasure to be moderator in this second day of ninth Middle East Pediatric Gastroenterology course and nutrition. It's my honor to present the first speaker, Dr. Osvaldo Puri. Dr. Osvaldo is a consultant pediatric gastroenterologist, head of pediatric gastroenterology, neurogastroenterology, and modality. He is an honored senior lecturer in pediatric gastroenterology, University College of London, Great Ormond Street Hospital for Sick Children. Dr. Osvaldo is one of the experts in pediatric reflux modalities and pseudo obstruction, and he's going to present a talk about update in eosinophilic esophagitis. Floor is yours, Dr. Osvaldo.
Oh, Dr. Hosasa, thank you so much indeed for your kind introduction. I'm going to share my screen. Hopefully everything is okay. Yes, you can confirm.
Yes.
Today in the next 20 minutes or so, I'm going to go through the eosinophilic esophagitis, which, as everyone knows, has got an increased prevalence and incidence in the last few years. It's defined as chronic immune antigen-mediated esophageal disease, and actually the main aspects are symptoms like symptoms of dysphagia, food impaction, heartburn, mainly in older children and in adults. We will see also in younger children which type of symptoms they have. We can have specific endoscopic abnormalities, but the most striking aspect is eosinophilic infiltration of the esophagus. Usually we have at least 15 eosinophils per high power field. The first case report was in 1977, and there's been a significant evolution in the last decades. So we had the first as recognized entity in the 1993-95, and during that time there was the first published study in children where we had 12 children with refractory gastroesophageal reflux, which were treated with elemental diet, and all of them respond to the diet. And also there was a resolution of the eosinophilic infiltration of the esophagus. The first guideline was done in 2007, then the second consensus in 2011, then we had first European pediatric guidelines in 2014, and finally another guidelines 2017. So the field of pediatric gastroenterology regarding eosinophilic esophagitis has been very intense in the last 15 years. Also, the incidence has significant increase, and you can see this is a review published a couple of years ago, and you can see how in the States there was significant increase of the case, and actually the incidence range between 5-10 cases for 100,000 subjects. Also the prevalence, and prevalence is very interesting. So we have actually overall full prevalence essentially is around 22 in 22.7 per 100,000, and actually the prevalence is higher in adults than in children. In children is around 29.5 per 100,000 subjects. These are much more frequent in Western Europe, North America, and Australia, much lower in Japan and in China, so in Asia. However, there are a lot of studies from the Middle East have been published, and showing how this disease is becoming more frequently recognized. What about the pathophysiology? So we know we are just facing a multi-factorial disease where we have an predisposing heartbeat. These patients, as we can see later, they have high rate of allergic rhinitis, asthma, atopic dermatitis. And then there are a specific pathology. Then we have genetic cause. We don't have a specific genetic cause, and though we have some Mendelian disorder and can be associated with eosinophilic esophagitis. But we have some candidate gene. A lot of study regarding genetics have been performed in the last decade. It's more prevalent in a male. There is a ratio male-female 3 to 1, and that we have predominantly, as I said before, in Caucasian population. So in general, we can think that we have specific genetic abnormalities which can affect the barrier function and cause the dilatation of intercellular space. At the same time, some genetic abnormalities involve the inflammatory cascades. We have food antigen and hydroallergens, and eventually environmental factors are able to induce and transmural inflammation, which can cause an accumulation of eosinophils in the esophagus, which with the time, this inflammation can cause a subsequent fibrosis, which in turn cause stricture and small caliber esophagus. Regarding the in general, so regarding the most striking aspect of eosinophilic esophagitis, we have a characteristic Th2 inflammation, and this Th2 is characterized by an increase in IL-4, IL-13, IL-5, and also an increase TGF-beta. TGF-beta is definitely involved in remodeling, which can cause stricturing and narrowing esophagus, while other cytokines are mainly involved in recruitment and of eosinophils, and then therefore in eosinophilic infiltration. So we have Th2 cytokine profile, which predominates in eosinophilic esophagitis. What about the tissue modeling? Tissue modeling is an important aspect of the eosinophilic esophagitis, mainly when it is untreated. We know that one of the main mediators in remodeling, which cause epithelial hyperplasia and fibrosis, smooth muscle hypertrophy, is caused by TGF-beta1, though also IL-13, IL-4 have been involved in the pathogenesis of fibrosis. So in general, we can have different type of phenotype. So we have an inflammatory phenotype which can be associated with this motility, essentially, but we can have also an fibrostenosizing phenotype. In general, what has been suggested in the last few years that essentially in the initial phase of the eosinophilic infiltration, we have mainly an mucosal inflammation. With the time, if the inflammation is not cured, then we can have a subsequent fibrosis and then esophageal narrowing. And for that reason, it's very important, mainly in children, to establish the correct diet, so at least we can avoid narrowing in young adult and in adult. Later, of course, for esophageal restriction, we require recurrent dilatation. We have a specific phenotype, but seems we also have a specific what we call endotype. So based on genetic and gene expression, we can have different type of phenotype. It has been just published last year that we can have two different, essentially endotype. We can have, the first group where we have atopic patients. They are very sensitive to the treatment, and that can be mainly in the pediatric age. In the pediatric age, we can have some steroid refractory patient. This is the second type of the second endotype. While in adult, the endotype is mainly characterized by non-atopic patient and fibrostenotic abnormalities. So we have seen that we have a ratio between male and female 3:1. It seems that actually there is involved, the estrogen, which can cause expression of specific genes and then can cause less in female, less esophageal remodeling and less barrier dysfunction. So about the clinical presentation, so in children, we have mainly in young children, we have failure to thrive of feeding difficulties. We can have also nausea and vomiting. Those symptoms are generally speaking associated with the gastroesophageal reflux, but this gastroesophageal reflux is quite, in some cases can be refractory. Then we have abdominal pain, we have heartburn and picky eater. While in adult, in young, in older children, in teen, and in adults, we have dysphagia, slowly, these eating slowly. Sometimes they try to avoid some solid food, like, for instance, meat, bread, pasta, and chicken. They try to avoid, and that can cause social difficulties. They can have chest pain and heartburn. So just to, so it's quite common in adults. We have intermittent dysphagia and food impaction, while in children we have mainly gastroesophageal reflux symptoms, heartburn and regurgitation, and that can be PPI dependent or PPI resistant. In children, we can have also dysphagia, food impaction, and that is happening usually later on, so during the adolescent age. What about the relationship between EOE and allergy? So a personal history of allergy is very common and present in more than half of the patients. So the majority of the patients with eosinophilic esophagitis are sensitized to either allergen, food allergen, so they can have a positive IgE or prick test, although this disease is not IgE mediated. A small proportion of EOE patients do not suffer a small proportion of concomitant autopsy. And sometimes the offending food can be identified by allergy test. I will show you later. The skin prick test and the patch test can be useful in addressing the treatment and the diet. However, it's important to recognize the fact that they do not routinely demonstrate the trigger foods. So food allergy is present up to 43%. There is a possible common trigger between eosinophilic esophagitis and other allergies. We have also some evidence that there is exacerbation of the disease during the pollen season. So at the beginning of the summer and ahead of the summer, sometimes we can have an increased eosinophilic infiltration. What about the classification? So essentially, the eosinophilic esophagitis is defined based on the fact that there are no other cause of eosinophilic infiltration of the esophagus, for instance, candidiasis, or for instance, IBD, or gastroesophageal reflux disease. So in general, we have a primary eosinophilic esophagitis. We can be atopic, as we have seen before. Non-atopic can be familial. So about the endoscopy, so we have different lesion. We can see endoscopically. We can have edema, we can have rings. We can have white exudate, as you can see here. So there are very small white plaques. We can have furrows, and these furrows. It's a linear lesion which progress from the proximal to the distal part. Then we have stricturing, and finally we can have combination of endoscopic abnormalities. In terms of endoscopy, so a few years ago in 2013, some adult, in collaboration with the children, have done with the pediatric gastroenterologist, have tried to come up with an endoscopic reference score, which essentially is quite easy. So based on evaluation of fixed rings, exudate, furrows, edema stricture, and crepe paper esophagus, you can classify properly each patient with eosinophilic esophagitis. And of course, with the time, you can review the endoscopic score based on the treatment that you have started. Esophageal, this is an example of esophageal rings. This is an example of narrow esophagus, caliber esophagus, linear furrow, and white plaque exudate. Usually, the last white plaque exudates are much more common in young children, while also linear furrows. Then the narrow caliber and esophageal rings can become much more frequent in adults. The narrowing, of course, is associated with narrow caliber and esophageal rings with chest pain, dysphagia, so for solid food impaction, while the other edema and white plaques, linear furrow, are much more associated with difficulty in eating, nausea, and vomiting and abdominal pain. So biopsy needs to be done always. So, and this is a key aspect. So in order to assess, to make the diagnosis, and also in order to assess the results, the response to the treatment, we need to perform all the time, biopsy. We need to perform 2 in the proximal, 2 in the middle, and 2 in the distal. And, just to clarify that, when you do at least, 6 biopsy, we have a sensibility of almost 100%, while you have, less sensibility if you have, if you have, I don't know what happened to, sorry, 1 second. So I think I'm back. Yeah. So we have less sensibility if we perform less biopsy. So 84% with just 2 biopsy. The diagnosis is done when we have a number of eosinophils above 15 for high power field. However, other abnormalities are recognized recognized on histological assessment, like basal hyperplasia. So the presence of is here, the presence of eosinophils at the level of the superficial layer, and also the presence of micro abscess, as you can see at that level. Before, a few years ago, until 2014, there was the diagnostic protocol. So we have a patient with suspect on PPI treatment, or patient with suspect EOE. You do the biopsy. So we have 15 eosinophils for high power field. Then you start the trial with PPI. If the trial with PPI was effective, you used to make a diagnosis of PPI responsive eosinophilic esophageal eosinophilia. If the patient were refractory to PPI, then you could make a diagnosis of eosinophilic esophagitis. The things, trial of PPI was a key aspect of the diagnosis of eosinophilic esophagitis. Only on those patients not responsive to PPI, you could make diagnosis of eosinophilic esophagitis. Essentially, we have seen a huge change in the last 15 years. So first, has been seen how almost, a prospective study have seen a very good response of eosinophilic esophagitis to PPI. A lot of studies have shown that actually PPI are able not just to decrease the acid in the esophagus, but also have an anti-inflammatory mechanism. So what happened? So then we also have some clinical features. So as you can see here, there are 3 groups. we have gastroesophageal reflux, then we have eosinophilic esophagitis and PPI responsive esophagitis. And, based on a number of studies, they have seen that there was no difference at all between PPI responsive esophageal eosinophilia and eosinophilic esophagitis. And there was striking difference with patients with gastroesophageal reflux disease. Interesting also study where they have used a molecular eosinophilic esophagitis diagnostic panel with almost 94 selected genes. So studying the transcriptome, what they've seen, and going next slides, how the gene expressed in patient with eosinophilic esophagitis and PPI responsive esophagitis were essentially the same. So just in summary, there is no clinical pathological and diagnostic difference between eosinophilic esophagitis, PPI responsive esophageal eosinophilia. So, and also there was no molecular genetic difference between the two groups. So in general, what has been decided that actually the PPI trial was not required. So once we have a patient with eosinophilic esophagitis, the PPI is a part of the first line treatment together with other treatment we will see later, like steroids and diet, but it's not a different disease. So which therapeutic option we have? So we have PPI, and we know that we have an efficacy and around between 40 and 70%. Then we have in terms of long-term adverse effects, we know that that can cause recurrent respiratory infection, that can cause problem with the vitamins, they can also predispose in some patients to allergy, that can cause recurrent gastrointestinal infection. There is also a long discussion about fracture and abnormal bone metabolism. Then we have 6 food elimination diet, where there is an efficacy of 72%. Of course, there is less cost, less side effects. Unfortunately, we need a significant number of endoscopy, to assess the efficacy of the treatment. And then we have topical steroid. Again, we have the similar efficacy around 70 and 85%, and there is equivalence between fluticasone and budesonide, although we do not have a specific head-to-head comparison between the two drugs. Okay, so in general, so we have a specific framework for classifying treatment response in eosinophilic esophagitis. So we have the no response, response, and complete normalization. So no response, where we have persistent eosinophilia, we have persistent symptoms, and also we have persistent endoscopic findings. While those patients who respond to the treatment, we have decrease eosinophilia at the level of distal proximal esophagus, usually can range between 1 and 6 and 7 and 14. Decrease symptoms of at least 30% based on the SAM score used in the literature, and improve endoscopic finding. While complete response, complete remission, we have absence of eosinophils, almost completely symptom resolution, and the normal esophagus at the endoscopy. However, we need to accept the fact that the choice in the therapeutic option can be driven by the disease severity and also by age, and also by patient choice. There are some patients that prefer to start medication instead of starting the diet because they do not want to change the quality of life. For this reason, usually there is a need to have a big discussion with the family. What is the best treatment for them? So, for instance, elemental diet is effective on 91%. Skin allergy tests, we know, unfortunately, only in 50% can direct the diet. We can have an empiric 6 elimination diet, as we have seen before, is effective 72%. Now, the 6 food elimination, the most common are milk, wheat and gluten. Then we have egg. Then we have nuts, and then we have fish. and soya. No, the problem is every time we reintroduce foods, then we need to scope, then we need for each food, we need to scope, and in order to identify the specific antigen. And it's been calculated that almost 42 weeks you require to do this process. And, the number of endoscopy vary between 14 and 18 in order to identify the culprit of eosinophilic esophagitis. So there is a discussion if we should have a step-up approach. So we should start from 2 feed, and usually the 2 feed, the two foods are cow's milk and gluten and gluten wheat, or 4 feed elimination diets, gluten, wheat, cow's milk, soya, and egg, or 6 food elimination diet. Or we should start on the top-down treatment, top-down diet, which is quite complicated, and of course, discussion with the family is definitely needed. Full food elimination diet is effective almost in 44% of adults, while in children it's much more effective. So almost or more than 2/3 of the children are responsive to the diets. Anyway, so we know that we have cross-reactivity between food, for instance, cow's milk and soya. So we need to be on cow's milk and goat milk. So we need to be sure about we address this issue with dietitian. So in general, the first consensus when you decide specific dietetic therapy, other ends, the family research needs to be considered, and a dietitian needs to be involved in order to discuss continuously with the family all the aspects regarding the diet. About the treatment, we have essentially topical steroids, and fluticasone in adult is 800 micrograms twice daily, in children 440 milligrams twice daily, though higher dose can be used. What about systemic steroids? Essentially, there is one study comparing systemic steroid with topical steroids, and they show the same efficacy. However, systemic steroid had significant more side effects. So topical steroids.
2 minutes, Osvaldo. 2 minutes left.
I'm trying to be quick. So topical steroids can be borrowed by, and of course, asthma medication. There are fluticasone and budesonide that most common applied. At the moment, they are not formulating for an esophageal eosinophilic esophagitis, though there are new oral dispersible tablets. They are able to decrease the inflammation, eosinophilia, the apoptosis, decrease the mast cells, and so on, and regulate the gene expression. And as you can see here, there is definitely a significant efficacy of budesonide, compared to placebo, as you can see here. And there is also the main issue essentially is the risk of candidiasis, which can happen in almost quite, its risk relative is 3.9. 25% in children do not respond to the budesonide. There are new formulations that are able to essentially improve the compliance, and maybe at the moment they are only approved in children. I want just to go a little bit faster because we don't need to see, this is just about the efficacy of budesonide. It's about, the last biologic treatment. So it has been used a lot of biologic. So, addressing the IL-4, IL-13, IL-5. And there are a whole other, so I think we have also other biologic addressing the anti-TSLP and A1AT. The main problem essentially is that we have also other biologic addressing. The main problem that these biologic at the moment are able to mild decrease the number of eosinophils in the esophagus, and also the improvement of symptoms is not so satisfactory. Of course, in patients with refractory disease, unfortunately, we need to consider different strategy, because as we have seen before, and persistent eosinophilic esophagitis can cause fibrostenosis and esophageal narrowing. Thank you so much indeed for your attention, and I really hope I have been on time.
Thank you very much, Prof. Osvaldo. I think the topic of eosinophilic esophagitis is most exciting For attendance, please, if you have any questions, please write your question on chat. And at the end of session, we will answer your questions. So the second speaker is Professor Mustafa Saleh. Professor Mustafa Saleh is a consultant pediatric neurologist. He's one of the experts in pediatric neurology. Why? Because he has more than, mashallah, 255 publications and more than 32 book chapters. And recently in 2020, he published clinical childhood neurology. Also, Prof. Mustafa is known of two diseases called Saleh myopathy and Saleh ataxia. Prof. Mustafa is going to talk about neurological complication of malabsorptive syndromes. Prof. Mustafa, floor is yours.
Thank you, Mr. Chairman, for the introduction. And it is a pleasure and honor to join this meeting. And I would like to thank the organizing committee for all their efforts first, and Professor Asad Asiri for the invitation to present the neurological complication of malabsorption syndromes and are preventable and treatable in this meeting. And what I will do is to go over what has been done regarding the neurological complications of malabsorption syndromes internationally, in the Middle East, and one local study which we have done here in collaboration with the colleague as well. So the defective digestion, absorption, and transport of nutrients across the bowel wall present with neurological and psychiatric symptoms. They can present with ataxia due to vitamin E deficiency or vitamin D3, niacin, as pellagra, vitamin B12. They can present with sensory neuropathy and due to vitamin E deficiency, impaired cognitive function, dementia due to vitamin B3 deficiency, headache, psychiatric manifestations, depression, schizophrenia, anxiety, seizures due to vitamin B3 niacin, which causes pellagra, and epilepsy. Epilepsy is 1.8 times more prevalent in patients with celiac disease compared to the general populations. And to have the ataxia will look like this one, tandem gait. They can't walk with their heel to toe walking, becomes very difficult, as is seen in this girl. The literature reflects this. This came 2 years ago, neurological manifestations, neuropathy, and ataxia in celiac disease, systematic reviews. And in 2 publications, you can see in children, you can see ataxia and neuropathy or ataxia alone. The conclusion is that many patients who present with neurological manifestation of celiac disease have no gastrointestinal symptoms, and that there is a need for physicians to consider celiac disease in patients with ataxia and neurological manifestations of unknown etiology. The pathology of gluten ataxia involves the cerebellum, loss of Purkinje cells, atrophy, gliosis, and astrocytosis, and lymphocytic infiltration, perivascular cuffing with lymphocytes. In patients with large fiber neuropathy, there is an axonopathy. As seen here, this is from our collection, a nerve. You can see these are the myofibers with some myelin, and the axon in between it is packed. In a child with hereditary sensory neuropathy, for example, it can be very sparse because of the loss of the myelinated fibers, the myelinated fibers. There is an inflammatory infiltrate in muscle in myopathy and in the cerebrum of patients with encephalopathy and patients with epilepsy. A study by the Prince Abdullah bin Khalid Celiac Disease Research Chair reflected on the neuropsychiatric manifestations of celiac disease, clinical characteristics of celiac disease, and dietary adherence to gluten-free diet among Saudi children. So they had mood changes in the form of depression and anxiety in about a fourth of them, compared to the regular presentation like chronic abdominal pain in more than half of them. This is a study from Middle East countries where 48 years ago by Dr. Jafar ibn Suleiman, who is an authority in and the late Professor Mahmoud Mahmoud Hassan, and they put a patient on gluten-free diet in 1973. They had a follow-up of to this by Professor Jafar ibn Suleiman, published in Gut 5 years later, and they said all patients had poor appetite and were miserable. And it shows also the myopathy. The child could not stand. And this is after treatment. So there is an increasing interest in the association of celiac disease with neuropsychiatric disorders in children. And this is in a Swedish registry. It was found that children with celiac disease had a 1.4-fold greater risk of developing future psychiatric disorders in the form of mood disorders, anxiety disorders, eating disorders, behavioral disorders, attention deficit hyperactivity disorders, autism spectrum disorders, and intellectual disability. This is why special diets was used for treatment of autism and for ADHD, and by the use of gluten-free diet and casein-free diet. However, these proved not to be effective, and this is reflected in the book which we published recently 6 months ago on clinical child neurology. So in the chapter on autism spectrum disorders by Salih al-Salhi and Ilham al-Hifzi, almost all complementary and alternative medicines have no effect on core features of autism and are not recommended by the international scientific bodies like American Psychiatric Association and CDC. In the clinical management of ADHD by an authority who's Robert Needleman, there is less evidence supports the use of many complementary and alternative medicine for the treatment of ADHD. Elimination of these are difficult to implement and may help a small minority of patients while offering no benefit to the majority. Another study by Ajib on celiac disease in the Red States in Sudan. In 172 patients, 61% of the confirmed cases had gastrointestinal symptoms, whereas 61%, 39% of the confirmed cases had other features like stunted growth, bone or joint pain, anemia, skin manifestations, and peripheral neuropathy. A prospective hospital-based study by group also in Sudanese children with clinical features suggestive of the disease, involving Professor Zain Karnar, who's also an authority on gastroenterology. It's a persistent hostel-based study. 8 children, 15 to 18 months, who presented with appetite, weight loss, pallor, and proximal muscle wasting and weakness. And 38% were deemed strongly suspicious for the disease, and 60% of these were diagnosed with celiac disease following endoscopy and biopsies. And you can see the proximal myopathy here. The child has to climb up his leg to rise up. Celiac disease can also be symptomatic at presentation, especially in children from high-risk groups. And 3 of the high-risk groups are neurocognitive phenotypes, which can be detected by the general pediatrician. One of them is Down syndrome, known to everybody. The other is Sternal Syndrome. You can see the webbing of the neck, the low hairline, the wide space nipple, and the pectus excavatum, and the wide carrying angle. And Williams syndrome, this is also a patient which you saw, prominent forehead, maxillary hypoplasia, long philtrum, pointed chin, large ears, and a pleasant complexion. They are pleasant people. Going on, the gluten sensitivity can present as sporadic ataxia. Among 104 patients with sporadic ataxia, 12 presented with gluten sensitivity, and the neurologic symptoms were not related to hypovitaminosis or inflammatory CSF changes. They had ocular abnormalities, gaze evoked nystagmus, saccadic slowing, and upward gaze palsy like this one patient. He cannot look up to see the camera. And the gaze evoked nystagmus looks like this one. When he looks to one side, the eyes will jerk of the child. The extracerebellar features included deep sensory loss, bladder dysfunction, reduced ankle junction, and these were in electrophysiology were confirmed. So it looks a peripheral neuropathy. And the feature of peripheral neuropathy, if you ask a child to outstretch his hands, there is this called sign, which is clawing. And which is this clawing. And also there is, in the lower limbs, there is distal wasting and weakness. And also this equinovarus deformity. There is an entity of celiac disease, epilepsy, and cerebral calcifications. It's a rare emerging disease, first described in 1992. And to date, fewer than 200 cases were reported worldwide. Can present with occipital seizures, and it may be due to folic acid deficiency. And the calcification may first be the first clue to the presence of celiac disease. As you can see here, in 4-year-old child, you can see the calcification and then becomes more dense with time in Lee et al. Hereditary foliate absorption with extensive intracranial calcification is another entity, a rare specific defect of the absorption of folic acid from the gastrointestinal tract in the absence of malabsorption of any other nutrient. And this is due to a homozygous or compound heterozygous mutation in the SLC46A1 gene, and which is encoding the proton-coupled folate transporter. The important thing is that parenteral intramuscular high-dose oral folinic acid is, or the active isomer can obviate the symptoms and treat the disease. Then next to that is vitamin E deficiency, which has a big role in neurological complications of malabsorption syndrome. It's essential role in stabilization of cell membranes. Deficiency occurs in conditions causing fat malabsorption like celiac disease, cystic fibrosis, chronic cholestatic liver disease, A beta-lactoproteinemia, short bowel syndrome, and isolated vitamin E deficiency syndrome. And in A beta-lactoproteinemia ataxia and vitamin E deficiency, it's caused by mutations in the MTP gene due to improper packaging and secretion of apolipoprotein B containing particles. And the onset is early, first year of life, and it is symptoms similar to those observed like Friedreich's ataxia, but without a malabsorption. And there is acanthocytosis. You could see the red cells have a spike like the COVID-19 virus, and they have retinitis pigmentosa. They can get blind. You can see it here in the retinal image. And symptoms improve with diet therapy and vitamin supplements. There is ataxia with vitamin E deficiency. And this is important also, manifests between the ages of early teens, 5 to 15 years, and spinocerebellar ataxia, areflexia, proprioception loss, exactly like Friedreich's ataxia, and inherited as recessive, and it is quite prevalent in Middle Eastern region. One in a million in the world, 1 in 100,000 in Tunisia. The work of the late Professor Ben Hamida. The triad is just like that of Friedreich's ataxia, which we have revised in Uppsala with the colleagues and teachers in the Department of Pediatrics and Neurophysiology in Uppsala University in Sweden. The areflexia looks like this one. You don't have any, the reflexes are lost, both in the knee and in the ankles.
Prof. Mustafa, 3 minutes left, Prof. Mustafa.
Okay. So we'll now talk about, in the last 3 minutes, about our work in collaboration with the Division of Pediatric Neurology and Gastroenterology, Professor Asad group, and in which we looked for neurological manifestation of children with cystic fibrosis and cholestatic liver disease. These are children known to have cystic fibrosis or cholestatic liver disease, and who were found to have any neurological manifestation on follow-up over a period of 5 years, and they were referred to us in neurology. And diagnosis was based on clinical and laboratory findings, along with imaging and histopathology evidence. Vitamin E11 were done for all patients, followed by vitamin supplementation. There were 10 patients, cystic fibrosis 6, cholestatic liver disease 4, biliary atresia 2, neonatal hepatitis 1, metabolic liver disease 1, 7 males, 3 females. Consanguinity was high in 9 patients. Delayed growth in 10, all of them. Delayed milestone in 7, generalized muscle weakness in 5, ataxia in 2, reduced deep tendon years in 9, and ophthalmoplegia 6, proximal muscle weakness and wasting in 4, and gaze apraxia in 2. So to differentiate ophthalmoplegia looks like this one. So the child, if you ask him to follow, he cannot look, move the eyes either side to side or up and down. They are frozen. The gaze apraxia looks like this one. You ask the child to look to one side and the other. The head moves to one side first, and then the eyes will follow. This is called ocular apraxia. And so vitamin E were less than 1 milligram per liter in all of them. All patients responded well to treatment. Resolution of all symptoms in 3 to 6 months period, and correction of vitamin E level when repeated on follow-up was good, 6 to 15 milligram per liter. So to end this, I will end with one message, is that neurological complications of malabsorption syndromes are preventable and treatable. And the pediatrician needs to think about it always. Thank you for your attention.
Thank you, Prof. Mustafa. It is an exciting topic. And now, because we are 10 minutes delayed the program, so we have a lot of questions. So, Dr. Osvaldo, are you ready?
Yes, I'm ready.
Yes.
Just start
So-
my video, yeah.
Okay, so let's read you the questions. There's a question, 2 or 4 question for you. The first question is for how long I should treat topical steroid if the dietary therapy is not a choice, either because of non-response or compliance. The questions for how long they use.
Oh, it's an amazing question. It's very good. Usually you should have at least 12 weeks of treatment. Then you should reassess the patient with an endoscopy. The problem if the patient, of course, responds to the treatment, the question how long to carry on with maintaining this treatment. At the moment, there are no clear data, and also there are no clear data what is the dose. So it has been suggested that eventually half dose of budesonide, half dose of fluticasone dipropionate should be effective in maintaining the remission. But we are still waiting for better papers, because at the moment these are unclear. In the clinical practice, so we carry on with the treatment as long as we can. If there are no significant complications like candidiasis or adrenal axis suppression, so we review the patient and we try to win, and then we see, if the eosinophilic esophagitis, represent.
Okay, in the same tunnels, they ask about when you use the treatment, when you are going to repeat the endoscopy.
Yes.
And if there is any strictures, shall you dilate? And if yes, shall we dilate it in first session endoscopy or later?
It's challenging. Usually the stricture in the young children are inflammatory. So it's quite common that this stricturing tend to reverse just with the treatment. So in young children, because there is a higher risk of perforation, so I tend to start the treatment with steroids and just to see what is the symptomatic outcome. Of course, after a number of weeks, usually after 12 weeks, I will repeat the endoscopy. If there is no improvement, then in the following session, I'm going to do dilatation. In the older children and maybe in a teenager, so I tend to do dilatation at the same times, because and a dilatation will improve the symptoms. So I will do a dilatation and then we'll start the treatment. But the young children sometimes are a little bit more scared to perforate. So I think you can wait a bit.
Prof. Mustafa, you are with me, Prof. Mustafa?
Yes.
Yeah, there's a question to you. The question is, what do you do with a child with ataxia who respond partially to gluten-free diet?
One in the, if he has celiac disease, I mean, it's routine, as you know, you look for vitamin E, whether it is adequate or not,
Okay.
and the other ones. And call it in our experience, all those who had low vitamin E deficiency due to ataxia or to ataxia due to vitamin E deficiency, if you catch them early, the ataxia is gone. But if they are caught late, if you could call it, as you could see from the neuropathology, the lesion will be fixed. So all what you will be doing is stabilizing the condition. But it's important to think about it.
Okay. Another question, Osvaldo. It's smart questions. He asked, have you used any newer agent in treating eosinophilic esophagitis in patients with organ transplant recipient?
No, so we have used mepolizumab a couple of times, and unfortunately, the results was not great. So no, you see an reduction, a mild reduction in the eosinophils, but also the symptoms. There is mild reduction, but that they don't seem to have the same effect that you have with the biologic in inflammatory bowel disease at the moment. So there is no yet a good biologic can be used in eosinophilic esophagitis. So in patients with refractory symptoms or with complex symptoms, we are much more keen to consider elemental diet, even if we need to start, with the nasogastric tube instead of insisting with steroids, systemic steroids or biologic. So for a short course, 12 weeks of elemental diet, then usually is effective almost 100% of children.
Okay. I have a lot of questions, so this is why I would like at the end to close, to thank all the speakers. I think it's a very exciting topics, either from eosinophilic esophagitis or neurological complication of malabsorptive. So I would like to close the session, and thank you very much, and see you in the second session with other moderator. Thank you very much.
Thank you very much, Dr. Hassousa. This is Dr. Fawaz Al-Rifai. Assalamu alaikum all. I'm pediatric gastroenterologist from Kuwait, Ministry of Health. Would like to thank organizing committee for the kind invitation, and Prof. Asad Asiri. We're going to carry on with Dr. Osvaldo Borilli, who is a consultant pediatric gastroenterologist at Great Ormond Street Hospital in London. And he's going to talk about the lower GI involvement with eosinophils, with an overview about eosinophilic enteritis and colitis. Please, Dr. Osvaldo.
Oh, thank you. Thank you for the kind introduction. Before I start my talk, I had no time before we were a little bit, late, but I want just to say I'm so sorry that this year we had to do a virtual meeting. So it's very well organized and fantastic. A fantastic talk, but I feel a little bit sorry that I cannot join you. So I always spend fantastic days in Riyadh with and a lot of friends, and it's like a few days of my life when I can really enjoy, the work, but also the friendship. So I really hope that next year we can restart again the meeting face to face. So I'm sharing now. I think hopefully you see my screen. Do you see my slides? Yeah.
We can see it. Yes.
Okay, brilliant. So we can start. We are going to talk now, of course, behind the esophagus. So, which is a little bit more challenging topic because, the diagnosis and the symptoms are quite vague. And it's quite complicated. So I'm trying to give, an overview about what is happening in the literature. So in general, so we can define eosinophilic GI disease as a group of inflammatory disease of the gastrointestinal tract, clinically characterized by symptoms related to the GI segment involved, while histologically by a dense eosinophilic infiltration. And everything should happen in the absence of any other cause of eosinophilic infiltrations. Of course, the clinical pattern is influenced by the localization of the inflammation, by the extension, and also by the depth in the abdominal wall. We will see later. So essentially, we have primary eosinophilic gastrointestinal disease. We have talked, before about eosinophilic esophagitis. Then we have eosinophilic gastritis, eosinophilic gastroenteritis, eosinophilic enteritis, eosinophilic colitis. Then in the primary is also included the hyper eosinophilic syndrome with significant GI involvement. Then I know you know better than me that a lot of GI disease may manifest with eosinophilic infiltration, of course, celiac disease, food allergy, gastrointestinal parasitosis and infection, IBD, connective tissue disorder like Sternal Syndrome, and other disease like gastroesophageal reflux, asthma, and drug reaction. While we have on one side IgE-mediated pathologies like food anaphylaxis and protein hypersensitivity enteropathy like proctitis, infantile proctitis, and then we have non-IgE-mediated disease like celiac disease Ibd. Essentially, eosinophilic GI disease are a mix, between T1 and IgE-mediated and non-IgE-mediated reaction. In the majority of cases, eosinophilic gastritis, enteritis, and colitis, they are mainly characterized by delayed immunological reaction. Interesting, and this is just 10 years ago now, the situation has completely changed, maybe changed again. However, you can see how in almost 30 years there's been a significant increase in the number of publications which were addressing the eosinophilic infiltration of the gastrointestinal tract, and not just the eosinophilic esophagitis. The esophagus is much more easily accessible, also in terms of research and so on, but also on the lower gastrointestinal tract. What about the prevalence of eosinophilic GI disease? And we are talking about prevalence in absence. So in these studies, eosinophilic esophagitis was not included. And you can see how we have an eosinophilic gastritis prevalence between 1.5 and 6.4 per 100,000 subjects. Eosinophilic enteritis up to 8.3 per 100,000 subjects, and eosinophilic colitis 3.5. So as you can see, although they are a rare disease, the prevalence is significant, and also in the last year we have observed an increase in the prevalence. The prevalence is usually, and it's interesting, highest among children less than 5 years, while eosinophilic gastritis is a little bit more prevalent in the older age group. Differently from eosinophilic esophagitis, while the disease is more prevalent in male, in this case there is no difference in the age, also no difference in the sex. What about the pathogenesis? And I'll just quickly going through the pathogenesis again. We have an Th2 mediated reaction, though here there is some Ig-dependent reaction. Essentially, we know that the eosinophilic gastrointestinal disease can also be Ig-independent reaction, and this is testified by the fact that the allergy test unfortunately cannot identify the whole patient. So is a causal link a coincidence, the reaction with the allergy. So essentially, this is a study just published last year, and you can see that any atopic condition is present on almost all the patients with eosinophilic GI disease. Eosinophilic GI disease in eosinophilic gastritis in more than 50%, in 2/3 of the patient with the eosinophilic gastroenteritis, and half of the patient with eosinophilic colitis. And as you can see, the food allergy is present almost in 50% of them. So it's very common. So these patients are atopic patients, and half of them you can have a associated food allergy. So of course, which are the main common trigger? And we know that the most allergic, as we have seen for eosinophilic esophagitis, is cow's milk, soya, egg, and wheat and gluten. Unfortunately, beef. All the best food, unfortunately, we need to take out from the diet in order to manipulate and treat eosinophilic GI disease. So we now address the issue regarding the histology. And at the moment, the histology is a little bit still a matter of, it's still a significant matter of debate. This is normal value on children, in children regarding the eosinophilia. So as you can do in the hand room, is less than 10. Duodenum usually is around 15. Internal halium less than 20. In the cebum is the highest concentration. So we have this gradient that there is an increase in the cebum up to 35, and there is then a decrease in the number of eosinophils until reaching the rectum less than 10. So also we need to look at other histological abnormalities. For instance, we can find degranulated eosinophils. We can also see the movement of eosinophils in the laminar propria, and we can have eosinophilic cryptitis, eosinophilic crypt abscess. We can have the distribution, we can have the surface epithelium, we can have also the epithelial change, we can have also some other acute inflammatory cells involved, basal layer hyperplasia, elongated papilla, and in the duodenum also some villus atrophy. So it has been suggested initially that diagnosis of eosinophilic gastritis, we should have more than 30 eosinophils per high power field. Eosinophilic gastroenteritis more than 52 in duodenum, more than 56 in ileum, and eosinophilic colitis more than 100 in right colon, more than 84 in the transverse descending colon, more than 6 in right sigmoid. But in the last year, we have seen, in the last year, we have seen a significant number of study addressing the issue regarding histology. So I'm giving you where some of the problem can rely. Okay, so the definition of high power field. So if we define the high power field, the field of the view is 0.35, for instance, millimeters, we can have a number of eosinophils, which is 30, which is completely different if the high power field of the field of view is 0.225, which means, based on the type of histological assessment we do and based on the type of pathology lab we have, we can have a completely different count of eosinophils. And this is valid not just for the small bowel duodenum, for the colon, but also valid for the esophagus. So we have a number of papers published in the last couple of years, and there is an attempt to suggest a decreasing number of eosinophils to make the diagnosis. More than 20-30 in the stomach, more than 30-50 in the small bowel and the ileum, more than 50 in the right colon, more than 30 in the left colon. What about the endoscopy? We have a number of endoscopic lesions, as you can see here, an ulcer, you can see some nodules, erythema in the colon. Again, some erythema, you can have erosion in the colon and linear ulcer. However, almost 60-70% of a patient with eosinophilic GI disease, they have completely normal appearance. So what is the clinical pattern? First, we can have different form based on if only the mucosa is involved. We can have the whole wall and the muscle layer. We can have a serosal involvement in the mucosal form, as we can see later. Abdominal pain, weight loss, nausea and vomiting, diarrhea, bleeding in some patient with a significant involvement in small bowel. We can also have protein losing and neuropathy. When is involved the muscle layer, of course, we have motility issue, and we can have dysphagia if and we have the involvement of the esophagus. Then we have nausea and vomiting, gastric outlet obstruction. We can have some symptoms of pseudo obstruction in the small bowel. Is quite severe. If we have an serosal involvement, then we have ascites, eosinophilic ascites, and in some more complicated case, perforation. And then based on the segment of the gastrointestinal tract is involved, we can have a different plethora of the symptoms. So we can have in the esophagus, you know, we have seen before, feeding refusal, gastrovagal reflux symptoms, dysphagia, and food impaction. While if we have the involvement of the stomach, we have dyspepsia, functional dyspepsia, nausea and vomiting, irritable satiety, epigastric pain, a gastric outlet obstruction, and ascites. I want just to make note, there were a very nice case report where the muscle involvement in the stomach was the cause of pyloric stenosis in infants. Then we can have involvement of duodenum, and again, we can have nausea and vomiting, abdominal pain, diarrhea, weight loss, perforation, and ascites. We can have involvement of the ileum, we can have abdominal pain, perforation, obstruction, and ascites. And finally, we can have large bowel, and it is variable. We can have diarrhea, we can have constipation, we can have bloody diarrhea and abdominal pain. There are a few reports that have also the involvement of bile conduct and the pancreas, biliary tract and pancreas. So we can have jaundice, we can have cholestasis, epigastric pain, abnormal liver test, pancreatitis, and in some case, pancreatic abscess. So again, this study has been published last year, assessing almost 376 children. And as you can see, the most common symptoms is abdominal pain in more than 50% of the case, nausea and vomiting, almost 50% of the case, and diarrhea. Irrespective of the localization of the eosinophilic infiltration, we can have eosinophilic gastritis, gastroenteritis of colitis, essentially the same, the number. And also the constipation is quite common. So of course, the presence of constipation and diarrhea in a patient with eosinophilic GI disease raises question how is possible that the similar eosinophilic infiltration can cause completely different symptoms. However, at the moment, is still unknown. And this is, some clinical case we described here at Great Ormond Street, where the eosinophilic infiltration actually was localized around the nerve fiber in the small intestine, which cause a characteristic pattern of pediatric intestinal cell obstruction. So what is the burden of illness? So first, we know that we have a decreased quality of life. And as you can see here, compared to eosinophilic esophagitis patient with eosinophilic gastrointestinal disease had a significant psychological burden in terms of feeling of isolation on daily basis, as you can see the main difference, and also in terms of fatigue. So there was significant difference between patient with eosinophilic GI disease and a patient with eosinophilic colitis. In terms of the research utilization, so you can see how in the last 10 years, the number of endoscopy patients with eosinophilic GI disease has significantly increased. Unfortunately, anytime we start treatment, we see later, we need to reassess the patient because yes, we can have an improvement in the symptoms, but because there are very vague symptoms can be present also in condition like functional gastrointestinal disease, we need to be sure that the treatment we have put in place is effective, or at least the patient is not responding or not responding to treatment. We will see that later. And in terms of natural history, we can have different type of behavior. So we can have, for instance, one form where we have an initial flare, and sometimes it can be a trigger, can be an infection, for instance, cause an initial flare, and then we do not have any relapse anymore. Then we have other when we have recurrent flare up and recurrent period of remission, and then we have the third group where we have an initial flare, we have chronic disease that is unable to go on remission. So which type of therapeutic option we have? So again, we are not, so far from eosinophilic esophagitis. We have diet, we have 4 food elimination diet, elemental diet. This should be the first line treatment. Then we have steroids. It's different from eosinophilic esophagitis. Of course, we can use viscous budesonide for eosinophilic gastritis. However, the steroids needs to be systemic. We can use anyway also Entogort budesonide like we use on inflammatory bowel disease, and we can use Montelukast sodium chromoaggregated ketotifen. They are anti-allergic. Essentially the results unfortunately is not so excellent. Then we have some study, a few case reports suggesting long-term efficacy of azathioprine in those patients requiring long-term steroids. So we use azathioprine as steroid-sparing agent. And then there are a study again about biological treatment. So I will show you some data. Again, if we go back to the study published last year, we have, as you can see, there are a number of medication in all three conditions: gastritis, gastroenteritis, and colitis. And as you can see, the most common was, of course, the elimination diet. Although all some 6 food elimination diet are allergen specific, in some were elemental diets. However, a number of patients were also using immunomodulators and monoclonal antibodies. So it's a complicated condition to treat. So and we need to find what is the best treatment on a single patient. So I'm just showing some results. So in 2013, Dan Turner they show how in almost 12 patients the use of infliximab adalimumab was effective in maintaining the remission in patients with refractory eosinophilic gastrointestinal disease. This is a study in adults just published in the Digestive Liver Disease, showing that actually host use of vedolizumab, which is almost third-line treatment in infliximab bowel disorder, was able to induce the remission. And this is the last study, which is published just this year, where they use antibodies against Celiac acid binding immunoglobulin like lectin-8 is Celiac-8, which essentially is an inhibitor receptor expressed on mature eosinophil mast cells and just low dose on basophils. And they have seen that actually using this biological treatment, you can have some results both in terms of histology and in terms of symptoms. Unfortunately, at the moment, the number of side effects described in the study were significant. So what we can suggest, so essentially we can suggest in a patient with diagnosis of eosinophilic GI disease, so, and this is the histological diagnosis, histological number of eosinophils in the absence of other cause of eosinophilia. We consider whether we have surgical complication. If yes, then we consider surgical option. Otherwise, we consider full food elimination diet for 6-8 weeks. If there is a response, we continue for 12 weeks. Then we do the endoscopy. If there is no response, then we can consider other treatment, 5-SA in eosinophilic colitis, Montelukast, ketotifen. But in some patients, we should consider elemental diet or prednisolone or budesonide. We start with prednisolone 1.5 milligram per kilo, max dose 40 milligrams daily for 2 weeks. Then we taper. Maybe we can keep at a low dose 5-10 milligrams daily until 12 weeks. Or budesonide, we can start as an IBT and 9 milligrams, then we go down at 3 milligrams daily. Of course, if there is a response after 12 weeks, we need to always to consider to repeat the endoscopy, because it's important to clarify whether the treatment has caused histological remission, because some of the symptoms, again, I want to just remind everyone, can be functional and they are not caused by organic abnormalities. If there is a response, then we step down, we start food reintroduction, and we decrease, stop modulating the medication. If there is flare-up, of course, we start the diet of treatment. In a patient on long-term steroids, we consider steroid-sparing agent. Otherwise, we can consider some biological. So just take-home message is, the eosinophilic GI disease is an under-recognized disease. Accurate histological assessment is a key, a pivotal for the diagnosis, and we need to have, discussion with our pathologist about diagnosis. The diet is the first line approach. It's important to have a multidisciplinary clinic with these patients, so to involve an allergist and dietitian, and in some patients, as we have seen before, sometimes we need to refer to psychologists, and we need to escalate treatment only after appropriate evaluation, so scope the patient, see that there is the persistence of eosinophilic infiltration. Thank you so much indeed for your attention.
Thank you very much, Dr. Osvaldo, for this comprehensive review of such complex topic. Please provide us with the questions in the chat box. We'll get the questions after the end of the session. Now we are going to move our last speaker for tonight, Dr. Jonathan Hind. He's a consultant pediatric hematologist at King's College Hospital in London. He's a well-known figure in the field of intestinal rehab and transplant services. And he's going to talk about a topic that all of us as pediatrician and pediatric gastroenterologist don't want to miss, which is extrahepatic biliary atresia. Please, Dr. Jonathan.
Thank you so much, and thank you for the invitation to speak. I'd just like to echo what Osvaldo said. It's a shame this year that it's all virtual, and I am missing my friends in Riyadh. I do hope we'll be able to meet again in the not too distant future. So it's a bit of a change of topic from eosinophils. I'm going to talk to you about extrahepatic biliary atresia. No disclosures for this talk. So really I'll go through all of the background of biliary atresia, how you should diagnose it. It does present to family physicians, and then referred up to gastroenterologists, and finally to large tertiary and transplant centers. And it's something we shouldn't miss. Then looking at the management complications and the outcomes, and perhaps how we can improve some of those results. It is a rare disease, and that makes it difficult. That means that in a lot of the world, and even in the developed world, some of these cases are missed and present to centers that can manage the case too late. The etiology is unknown, but we'll come to some suggestions of what might cause it later in the talk. It's manifest in the first few weeks of life, and that's when you have to diagnose it. The incidence varies around the world. In Europe and North America, it's between 1 in 15 to 20,000 live births. But in Taiwan and other parts of Asia, it's as much as 1 in 5,000 births, very common in Taiwan and Japan and the Pacific Islands. In Saudi Arabia, the incidence isn't known. There's a very recent paper from a tertiary care center in Saudi Arabia. It doesn't tell us the incidence in the kingdom, but it does tell us that only 4.7% of cases with infantile cholestasis presented to their center were biliary atresia, which is much lower than what we find in Europe and North America, where it's one of the more common reasons for referral to a big gastroenterology center. 30% of those referred to liver transplant centers with biliary atresia. That's probably an overrepresentation because, of course, if biliary atresia is missed, then the liver will become cirrhotic and the child will need transplant. Most cases of biliary atresia, 90% are isolated. That means that the child has biliary atresia, but no other problem. But 10% it is with other abnormalities, known as syndromic biliary atresia. And the commonest abnormality to find with biliary atresia is splenic malformation. So here, that's the liver, bowel, where you should see a single spleen. You can see many little splenunculi. That's a splenic malformation. That's biliary atresia splenic malformation. The next common abnormality it's found with is a pre-duodenal portal vein. So the portal vein should be behind the duodenum, but this is in front of the duodenum. It's also associated with rotational defects, situs inversus, and cardiac abnormalities, and an absent retrohepatic vena cava. So knowing this does give us some hints to the etiology. Maybe it's an in utero developmental etiology. Thinking of the different incidences around the world, perhaps there's some genetic component to it as well. It can be classified into different types, and the commonest type is type 3, where all of the extrahepatic bile ducts are involved and atretic. The gallbladder remains, but it's often abnormal and small, or always abnormal and small. The classification types do vary between different countries, but again, this is the commonest type. So as I said, maybe it's some developmental abnormality, maybe it's something that's happening in early gestation. Certainly that must be possible. Cystic biliary atresia, where you can see a cyst at the porta on ultrasound, is detected on antenatal ultrasound scans. And some very early work showed that there were changes in the amniotic fluid, suggesting that there'd been biliary obstruction in the second trimester of the pregnancy. As I said, is it genetic? Well, we know there's racial differences in incidence. 1 in 15 or 17,000 in the UK, 1 in 5,000 in Taiwan. In New Zealand, they have a higher incidence in their Pacific Island population, but an incidence the same as the European incidence in their European origin population. It's associated with other genetic defects, and there are some animal models of biliary atresia, and they've inactivated various genes, which has led to biliary abnormalities. That's not coronavirus, that's actually CMV, and that brings us to infection. So viruses have been implicated, and of course, viruses which are attracted to the liver have been implicated, and in particular, the most work has been on CMV, and that's been found at a higher frequency in biliary atresia compared to controls in some studies, though the jury is out because other studies have found similar incidence between biliary atresia and controls. However, there are some mechanistic reasons of why CMV might cause biliary atresia. And from some of our own work in Kings and some animal models, it has been shown that CMV infection around the time of birth, and there's probably a small window when it happens that it can trigger this, triggers an autoreactive and autoimmune T-cell mediated bile duct injury. The biliary epithelial is damaged, but then the problem is this persistent immune mediated inflammation that's ongoing. Indicators of that have been detected in mouse models, and we think there's possibly a bile duct epithelia specific T-cell immune response. And our own work has shown that 50% of children with biliary atresia had abnormal expressions of an HLA-DR antigen and adhesion molecules, and with that there was an infiltrate of immune activated T cells and NK cells. And in fact, the inflammatory cytokines persisted in these babies up to 6 months after their Kasai portoenterostomy. So this is just showing you some work. So this histology A is an isolated biliary atresia, and you can see that Th1 lymphocytes are present in the portal tracts and in the hepatic plates. That's the bigger arrowheads, against a sample from someone with Alagille syndrome, where there aren't any T1 lymphocytes in the portal tract. C, again, is isolated biliary atresia. This is Il17 staining, and there's numerous portal lymphocytes. You can see there, you can see there, against a control sample with alpha-1 antitrypsin deficiency, where there aren't any Il17 staining. And this is Th17 infiltration. You can see there's a huge infiltration of these lymphocytes around the portal tracts of an infant with isolated biliary atresia, again showing that ongoing immune reaction. And it persists post Kasai portoenterostomy as well. So this is the group of children who cleared their jaundice. You can see they didn't really have many of these lymphocytes as opposed to those who did not clear their jaundice. It was an unsuccessful Kasai. They still had that immune reaction ongoing. What about another etiology? Although this is cloudy skies in this picture, this is in fact in New South Wales, Australia, and this is a dam there. And one season it was very dry, and the foreshore here, you can just see a little bit of it extended much further into the lake. And on the foreshore, a weed grew. This is a picture of that weed. And the farmers allowed their sheep to graze on the foreshore with all of this nice food that had been revealed this season. No problem, you might think, but in fact there was, because when all these sheep had their babies, the lambs all had biliary atresia. And the same thing happened to cows. The cows grazed on the weed, and the calves, the next generation of calves, had biliary atresia. So there must be some toxin from the weed that's affecting the animals in utero. Sometime later, an isoflavonoid was isolated. That was tested on zebrafish, and it caused zebrafish to get biliary atresia, and that's called biliary atresone, the flavonoid. So there could be toxins related and causing this disease as well. That's another possible etiology. And finally, some work that we've just published last year. The microbiome, of course, very fashionable in all areas of gastroenterology, and hepatology, it's getting fashionable as well. So there's been quite a lot of work on the microbiome in cirrhosis. This is just a cartoon, so it's showing all the different possible ways that dysbiosis might affect a cirrhotic liver, and these all really apply in the case of biliary atresia as well. So we have done some work. There's increased lipopolysaccharide binding protein in children who don't clear their jaundice after Kasai, as opposed to those who do clear their jaundice. So although evidence is currently lacking, this is definitely an area for research in the future, something that's possibly modifiable to try and improve the outcome of these children with biliary atresia. Moving on to the diagnosis, which is perhaps the most important part of the talk until these treatments might come on board. So one of the ways it's diagnosed is antenatally, and seeing a cyst at the porta on an antenatal ultrasound scan. And the possibility is that this is cystic biliary atresia. So they must be scanned, of course, after birth. The differential is a choledochal malformation. Either way, that will need surgery after birth. So these babies actually are diagnosed the earliest. They're referred to the tertiary center for surgery the earliest. They have their portoenterostomy the earliest, and they also have the best prognosis. Most babies, though, and this is where it gets very difficult for the physicians, family physicians in the community, or for gastroenterologists who may see very little biliary atresia, only very occasionally. So as we all know, neonatal jaundice is very common, about 50% of infants, particularly breastfed infants, and it's probably physiological between 24 hours and 2 weeks. But after 2 weeks, we would advise that all of these children still jaundice should have a blood test to check whether they've got conjugated bilirubin. And if that's more than 25 micromoles per litre or 25% of the total, that's defined as abnormal. And you can find on the internet, that's a link to the British Society of Pediatric Gastrohepatology Nutrition, guidelines of what to do if you find a baby with conjugated jaundice at 2 weeks of age. There's similar guidelines from the government in the UK, and the similar guidelines from other bodies around the world. And in fact, in the UK, if somebody sees a baby like this and doesn't do the test and misses biliary atresia, they will go to court, and they will usually get some money. The family will get some money, and the doctor will get in trouble for that. It's difficult because the liver disease is not severe yet, so the baby is like to be very healthy and thriving. They're often feeding extremely well, and that's because they're feeding to excess to cope with the malabsorption that they've got. A lot of mothers will say that. So you must examine these babies. You must look for jaundice, particularly in the eyes, and you must examine the stool. So again, in the UK, babies are seen by health visitors in the community in the first few weeks of life. Sometimes the mothers report jaundice. The health visitor doesn't look at the stool, and the biliary atresia can be missed just for the want of looking in the nappy. The accuracy of judging whether jaundice is present is difficult. It's also known that it's difficult in infants. The more pigmented the skin is, the harder it is to see the jaundice, so don't forget to look in the eyes. And again, we do actually see that in the UK, that black babies are more likely to present late because the community physicians or health visitors have missed the jaundice by not looking in the eyes. So always look in the eyes, always look at the stool, and if in doubt, check bilirubin and check total and direct bilirubin. When you do the blood test, these are the typical sort of blood tests that you might see. The cardinal one really is a raised gamma GT because of the biliary obstruction, obviously. And of course, conjugated hyperbilirubinemia, though I would say we've seen babies with a bilirubin as low as 30 who've still had biliary atresia. So you can't take blood tests as the only test that you need to do. The examination of the baby, the pale stool, and the blood tests all must be taken together, along with an ultrasound scan, and that should show an abnormal gallbladder. So a very thin, abnormally shaped gallbladder there. It should be a nice, big, black space. There's some papers where they've shown correlation with the triangular cord sign, which is this bright hyperechoic area, and that's fibrosis at the porta. That means the fibrosis is already present. I must say, in our own unit, we tried to validate these studies and we couldn't do it, but nevertheless, if you do see this sign, it's very suspicious. You may go on to do a radioisotope scan. So this is a normal radioisotope scan. The radioisotope is taken up by the hepatocytes and excreted in the bile. That's it in the common bile duct and later in the GI tract. But in a child with biliary atresia, the isotope is taken up by the hepatocytes, but however long you wait, none of it is seen in the common bile duct or in the GI tract. There's a much easier way to do this rather than put the baby through this scan, and that is, again, look at the stool, and if the stool has no pigment in it, there's no radioisotope that's going to be excreted from that liver either. You have to think of your differential diagnosis. In Saudi Arabia, the genetic causes of cholestasis, the PFICs, are very common. They're probably more common, or they are more common than biliary atresia, so don't forget to look at them. But often there will be differences, particularly in the ultrasound scan, stool colour, or the blood tests. These are some of the other ones. In the UK, alpha-1 antitrypsin deficiency is very common and presents like biliary atresia, and cystic fibrosis, which if not screened for can be easy to miss. And then when you do get to your big hepatology centre, there's a huge list of causes of infantile cholestasis that we have to screen for to look for the cause. The next step in diagnosis would be a biopsy of the liver, and it has some particular features. Number one is a hugely expanded portal tract. That's another one over there. It's expanded with lots of inflammation, edema. The bile ducts, there should be one, but in fact they try and proliferate as they try and go around the distal obstruction that's the biliary atresia. And you may also, I think you can't see that on this picture, but you may also see bile plugged up in the bile ducts because it can't be excreted lower down. If you're still unsure, the next step is a cholangiogram. You can do an ERCP. So here is the endoscope injecting dye into the papilla. That's the pancreatic duct. That's the common bile duct. So that's a nice liver there with nice biliary tree. In biliary atresia, of course, you can see that that dye does not reach the liver. So that's very suspicious that there's biliary atresia. And when the child goes to surgery, then the surgeon will put a needle into the gallbladder and try and inject dye the other way to see if they can demonstrate the biliary tree. And if not, then they will proceed to the Kasai portoenterostomy. So the management comes from Japan. That's Morio Kasai, a surgeon in Sendai, in 1959, invented the Kasai portoenterostomy, and since then that's a game changer for children with biliary atresia, and it's the primary management all around the world. What is the Kasai portoenterostomy? So you can see there is no bile duct, no common bile duct. That's biliary atresia. You need to drain that bile from that liver if the child is to survive. So you bring up a part of the jejunum up to the porta and use that as the drain. It's not as simple as a hepaticojejunostomy. You have to remove the liver. This is on the underside of the liver, so it has to be turned outwards, and the surgeon has to kind of dig into the liver until they find patent bile ducts to make sure that Kasai will work and that will drain. And the difficulty of the surgery is possibly why centralizing these conditions to surgeons who do quite a few of them a year might make the outcome better. Post-operatively, there's no gold standard, but again, the big units will have good standards of care and support from nurses and in the community for these children to try and improve the long-term outcome. Typical things that might be used: antibiotics to avoid cholangitis, enzyme inducing drugs to enhance the bile flow, possibly bile acid chelators or ursodeoxycholic acid to improve the bile flow. And another thing that's always debated are steroids, because it is an inflammatory condition in some of the cases, at least, or many of the cases. In our unit, we have looked whether steroids make any difference for biliary atresia. So we looked at 104 infants. Their median age was 45 days between January 2006 and June 2014. Most of them, of course, isolated biliary atresia. They had our standard post-operative regimen at the time. Some good nutrition in there, I must say. That's very important. And all of those received a course of steroids. This is some of the outcomes. This is clearance of jaundice. So for 30 days, 100% of them cleared jaundice. And if the Kasai was at 70 days, it's at about 62%. This is looking at native liver survival. If the Kasai was less than 45 days, it was well above 70%. It was over 45 days, about 50%. Did the steroids make a difference? Well, overall, 71 out of 104 cleared their jaundice. That's 68% jaundice clearance. All of those done less than 30 days cleared the jaundice. And the 5-year native liver survival was 69% in a Kasai less than 45 days, or 46 after 45 days. They compared that with the historical control. And in fact, the early Kasais at that time, they didn't all clear their jaundice. So there was perhaps an effect, positive effect of the steroids on Kasai's done early. On to complications. So the surgical complications are actually very unusual in experienced centres. We do about 40 Kasais a year and very rarely see any surgical complication at all. The commonest complication after that is cholangitis, which occurs in around 50%, and the number and frequency of episodes negatively influences the prognosis. And the next big thing is portal hypertension. All of the children really get fibrosis and portal hypertension to some extent. So that needs to be treated, perhaps with endoscopies, and if it's severe, it is an indication for transplant. There's more rare complications such as hepatopulmonary syndrome. In the interest of time, I won't go in detail into these. You can also get dilated biliary radicals in the liver, which are a risk factor for cholangitis again. And finally, malignancies. So you must screen regularly with tumor markers and ultrasound over the course of, or over the childhood of that child. You don't want to miss that, but it's actually relatively rare in biliary atresia. And finally, outcomes. So before the Kasai procedure, all the children died by around 2 years of age. And even after the Kasai was available, most children still died because a lot of them still got biliary cirrhosis. And it was transplantation in the 80s onwards that dramatically improved long-term survival. So what can you achieve? Well, clearance of jaundice within 6 months. So in around 60% of patients in developed countries that can be achieved. In our own series, 68% of children clear the jaundice by 6 months. And it's better with earlier Kasai. So in our series, if the Kasai is less than 30 days of age, 100% of those children clear their jaundice. And it's better if services are centralized to experienced centers. What about survival with the native liver? So nearly all of these patients survive now, either with their own liver or with a liver transplant liver. And of course, transplant data is very good. So our own data, our own survival is 90% at 1 year and 89% at 10 years. That's overall. Do they have their native liver? Well, it's around 50% of children at 5 years will still have their own liver. Again, that's better if the Kasai is done early. In our own data, 69% of children still have their own liver at 5 years of age if the Kasai was done less than 45 days of life. And at 10 years, we're just under 50% with the native liver in the early Kasai group. What happens if you survive very long term with your native liver? Well, there is a series from Japan that looked at 35 survivors who'd had their own liver, no transplant for longer than 20 years. 50% though had cirrhosis with some significant complications there, cholangitis and bleeding. 14% went on to have a liver transplantation in their 20s, and 5% died of liver failure. Another series from Malaysia, perhaps not so long survival with the native liver, but really all of these patients had significant cirrhosis with complications apart from one. And I'd say that one probably didn't have biliary atresia. What about Saudi Arabia? We're looking at your recent paper. Clearance of jaundice after Kasai in this center was 33%, so significantly lower than the Europe or Japan. And the native liver survival 14.3%. So again, well down on 50% that you might expect in Europe or Japan. Why? Well, in Saudi, there's a much later referral to pediatric gastroenterology with a median of 65 days. So you can see you're never going to get those babies like we have that would do the Kasai at 30 days and get 100% jaundice clearance. And of course, that led to a late portoenterostomy with a median of 73 days, where you can see that if you remember our own series, really, we only follow that data to 70 days. They're almost all done by 70 days. Why is that? Perhaps there's lack of knowledge, and this is statements taken from that paper. Perhaps there's lack of knowledge on the importance of the early diagnosis by pediatricians and families, lack of recognition of the importance of investigating prolonged jaundice in neonates older than 2 weeks of age. As I said, in the UK, there's national guidelines, and you will get in trouble if you don't follow them and miss biliary atresia there, so it's very different. Also, there's a missed opportunity for early detection of prolonged jaundice, as the first baby visit might not be until the well baby clinic at 2 months of age for vaccination, whereas in a country like the UK, health visitors go round to everybody's house and look at the babies in the first weeks of life. There also might be less access to the healthcare system from families who live away from the big cities. So a lot of really community problems that could change things for the outcome in Saudi Arabia. Other ways to improve outcome, screening. So Taiwan screened with stool color charts, and that led to earlier diagnosis. And you can see that Kasai's done less than 60 days of age, improved from 50% of them to 66, so that's good. And with that, the jaundice clearance improved from 35 to 61, and the 5-year native liver survival from 27 to 64%. So having a stool color chart would or should improve your early Kasai, doing your Kasai early with improved outcomes. And recently, with improvement in technology, there's now mobile phone applications for infant stool color recognition. This study from Bambino Gesù in the Vatican City in Rome, they used machine learning to get an algorithm that could then identify pictures of stools as normal, uncertain, or acolic. They validated the results by looking at the same pictures independently with 4 hepatologists, and all of the acolic stools were recognized by the app. So the sensitivity and specificity was extremely high. a positive predictive value of 98.4%. And in a way, the reason to do this, it's better than a card because parents can have that. It's on the mobile phone, it's in their hand. It doesn't rely on the logistics of health visitors visiting and looking at color cards, etc. That's just some pictures of the app. Very easy to use. Take a picture of the stool and the app then tells you what to do. Of course, if it's down this end of the color, it's telling you to ring your team. So screening and centralisation of services. So this was done in the UK to only 3 centres that look after biliary atresia and do Kasai portoenterostomies. So they looked at all 443 infants in the UK with biliary atresia in the 10 years after centralisation. And what happened was the median age at Kasai was down at 54 days, which was the fastest time to Kasai of any country, even including Taiwan, where it's the commonest. Clearance of jaundice went up to 55%, 1 and 10-year survival 90%, and native liver survival 46 and 40% at 5 and 10 years. And this is just a chart showing other developed countries and what they've done. With centralisation in the UK, you can see that our native liver survival has gone from 30% to 46 and 44 at 10 years. 55% jaundice clearance. So in conclusion, biliary atresia is a rare condition. The outcome is improved with early Kasai portoenterostomy, but to achieve that, you do need a great awareness across the paediatric community and out to families. That will lead to prompt referral to an experienced centre where experience can be centralised, given standard and experienced long-term management plans, and a rapid diagnostic protocol to diagnose biliary atresia and get to the Kasai early. And with that experience and centralised systems, you can reach an overall survival of 90% and the native liver survival at 5 years of more than 50%. Thank you very much.
Thank you very much, Dr. Hind, for this excellent comprehensive review of biliary atresia. We're going to start with the questions, first with Dr. Osvaldo. First question, when to suspect eosinophilic GI disease clinically to differentiate it from other diseases?
Oh, this is another good question. Unfortunately, it's almost impossible on a clinical ground to make diagnosis of eosinophilic GI disease. Essentially, the symptoms are very non-specific. So you can have symptoms overlapping functional gastrointestinal disorder like irritable bowel syndrome, functional dyspepsia, and symptoms overlapping IBD like bleedings, rectal bleeding, or protein-losing neuropathy. So essentially, when we have a complex patient with significant symptoms, the severity of the symptoms should push us at some point to perform the endoscopy. And based on the presence of significant eosinophilic gastroenteritis, then you can make diagnosis. As for the eosinophilic esophagitis, the eosinophilic GI disease essentially is a clinical pathological diagnosis. So it's difficult. And you don't have biomarker. So essentially, the endoscopy is a key part of the diagnosis.
Sure. Second question, can we use the same management algorithm for isolated eosinophilic GI disease and eosinophilic GI disease secondary to hypereosinophilic syndrome like Churg stress syndrome?
Oh, essentially, yes. Yes, now you can use the same. I will always prefer to start from the diet. Sometimes the diet can be direct from allergy test. Because differently from eosinophilic esophagitis, for Adhd, essentially you have systemic steroids. So on the balance, the pre-cons, it's always better to start the diet. But essentially, yes, you can start. You can use the same protocol, the same approach.
And last question from me. Where we see ourselves, is it like IBD for eosinophilic GI disease? Are we treating, aiming for mucosal healing? Since these are very heterogeneous group of disorder and the long-term outcome of the natural history not very conclusive.
Oh, you're absolutely right. So it's complicated. So essentially, theoretically, yes, you should have a mucosal healing. And a significant problem in this group of children is that sometimes you have an improvement in the number of eosinophils, but the symptoms are still significant. So, and there is always a risk to escalate the treatment based on the, the presence of symptoms. So essentially, it's almost an impossible answer, a very complicated question. So you're treating the patient, you're just addressing them from clinical basis, aiming to the best, clinical outcome. The need of repeating endoscopy, I want just to reiterate the concept that sometimes you escalate the treatment without, any eosinophils in the gut. So you start because you don't know if the patient is still complaining with the symptoms. And sometimes you repeat the endoscopy, they are almost completely normal, but they are still so symptomatic. Because that is possible, there is also a function component on the top. So we don't know the natural history of disease. So your question is very well done. Unfortunately, my answer is very poor.
Excellent. Thank you very much, Professor Osvaldo. Now with Dr. Hind, I get a question. Do you use MMP7 in evaluating infants with direct hyperbilirubinemia?
As in on the biopsy, you mean staining?
I think so.
Yeah. So I have to say we're kind of changing what we do to diagnose biliary atresia now. And if it's very clear, so if it's a healthy baby, 4-6 weeks of age, conjugated jaundice, high gamma GT and an abnormal ultrasound, we actually don't always do the liver biopsy now. So we only tend to do a liver biopsy if we're unsure of the diagnosis. So then certainly depending on what our thoughts are as to the diagnosis, we'll go on to do further staining on the biopsy, because then we're looking at things like genetic causes of cholestasis, for example, at different PFIC conditions. Biopsy as a tool is actually going down in importance as genetics becomes more important, because now we can do a lot of things on a blood test. So yes, it's the short answer, but only when we're not sure that that's the diagnosis.
I get correction. Do you use serum level of MMP7 in evaluating direct hyperbilirubinemia?
No, not usually, no. So the very simple blood tests are sufficient to get you to biliary atresia, I would say. Very important on the imaging findings. It becomes more difficult when it's not biliary atresia or not a clear cause of the cholestasis.
Sure. Second question, for how long you keep the prophylactic antibiotic after Kasai procedure?
So we do, our standard is 5 days intravenous antibiotics after the Kasai and then 1 month orally.
Okay.
I don't think there's any great evidence of how long they need to continue. Every big center has their own protocol. Nobody's done a trial to know which one is better than another.
Are you using orthodeoxycholic acid following Kasai procedure?
So not necessarily. So again, only if there's a problem. It's not in our standard protocol. In fact, some children we've seen where the bile has really not been excreted well, or the Kasai is failing, that we've had a problem with ursodeoxycholic acid because the bile acids are high, and they've actually had some symptoms with the ursodeoxycholic acid. So things like cholestyramine may be better to chelate it and pass it out of the GI tract.
Okay. I don't think I have any more questions. With that, I would like to thank both speakers for staying with us, like all the audience for joining us on the second day of the 9th Middle East course of Pediatric Gastroenterology, and wish you all a good night. Thank you very much.
Thank you. Hopefully I see you.
I would like to thank Dr. Osvaldo and Jonathan for this excellent presentation. They are actually our associate, Osvaldo from Ghosh and Jonathan from King. They're our associate and close associate over the last 9 years. with the Professor Nakil, but Professor Nakil will be with us on Thursday because of the time difference, because he's now doing sabbatical in Australia. I would like also to thank Professor Saleh for the presentation as international and national speaker. Professor Saleh is an excellent researcher. He is one of the really pioneer in research in pediatric neurology, and he is one of the authority all over the world, and he's known to be an excellent pediatric neurology. I would like also to thank Dr. Fawaz Al-Rifa'i from Kuwait, and also would like to thank my colleague, Dr. Muhammad Hassousa from Jeddah National Guard Hospital. Yesterday also, we had Professor Badriya Lawar from United Arab Emirates. She was one of the moderator. And also we had Dr. Ashraf Al-Sahafi from Jeddah National Guard. I would like also to thank all our colleagues in the Department of Pediatric and the Saudi Pediatric Association. And also I would like to thank my colleague in Susbigan for their support of course, doing this annual meeting. Thank you very much. And we'll see you tomorrow night. Thank you. Jonathan, thank you very much. Usually we meet annually, and we meet also in Riyadh. And of course, we always have national and local food on our overnight trip. But this time we're doing it online.
Unfortunately, yes, but we're coming next year.
Yeah.
Thank you very much all.
Thank you.
I would like also to thank Dr. Muhammad Timsah and Dr. Muddathir Hamid and Dr. Muhammad Kambal for being host and co-host for this meeting. Dr. Timsah as an excellent PICU consultant and associate professor, and also he's really, I always tell him that instead of you being a pediatrician, you should go to IT. Thank you very much.
Bye, guys. Bye to everyone.
Bye. Thank you.